Hi, my name is student Dr. Lacombe.
And I'm student Dr. Wren, and we're presenting on behalf of the Idaho College of Osteopathic Medicine and Idaho Urologic Institute.
Today's presentation will be discussing the surgical management of lower urinary tract symptoms attributed to benign prostatic hyperplasia.
The prostate is an important part of the male reproductive anatomy. The prostate is a walnut-sized gland between the bladder and penis that surrounds part of the urethra, which allows urine to flow out of the body. The prostate produces and secretes fluid that nourishes and protects sperm. Later in life, the cells that make up the tissue in the prostate surrounding the urethra can continue to grow and divide, which is called hyperplasia. Since the prostate tissue surrounds the urethra, the biggest problem patients face is difficulty with urination. This results in incomplete emptying of the bladder, dribbling after urination, hesitancy, prolonged urination, and potential complications of bladder inflammation. These are considered lower urinary tract symptoms. There's also a concern for prostate cancer at any point, which is why it is imperative for patients to seek treatment.
Prior to surgery, there are some medications that can be tried first. These will often be discussed with your primary care provider before referral to your urologist, but can also be discussed with them. The medications called alpha blockers mainly work by reducing the tension in the bladder by relaxing the bladder muscles. Another group of medications, called the 5-alpha reductase inhibitors, target a specific protein in the tissues of the prostate that seem to contribute to bigger prostates, reducing its activity and also the size of the prostate. The doctor will discuss the various options to determine which is best for your particular situation, to account for any other conditions you have, and also to discuss the side effects of these drugs.
If medications fail to improve symptoms significantly, surgery is usually the next thing to discuss. Several tests can be done to determine the severity of the symptoms. Imaging may be done to determine the size of the prostate to guide decisions on the best option for surgery, which we will discuss next. An important thing to understand is that although surgery can improve symptoms, there are always risks, and we'll be sure to bring up some of these as we discuss the treatments. These will definitely be discussed by your urologist and possibly your primary care doctor as well before the referral. All surgeries have risks associated with infection, anesthesia, and post-operative healing.
Transurethral resection of the prostate, or TURP, has long been considered the gold standard in the surgical management of BPH. It was first developed in 1926 and has been a tried and true method that has provided patients relief of lower urinary tract symptoms such as hesitancy, straining, prolonged urination, dribbling, or incomplete emptying for multiple decades. A decision is made with the provider to pursue TURP depending on how severe the lower urinary tract symptoms are. This procedure is conducted under general or spinal anesthesia and involves the use of a resectoscope. It is directed up towards the urethra to the area that is obstructed by the overgrown prostatic tissue. A current of energy runs through the loop and is used to swiftly remove tissue as it passes through it. An irrigant is also passed through the urethra and carries away removed pieces of tissue into the bladder, which will eventually drain out later. What can patients expect? After the procedure, which is usually around 60 to 90 minutes, a catheter is put in place for a few days to allow for draining of urine, along with residual blood and tissue. This procedure is very effective in alleviating lower urinary tract symptoms, and patients often notice an improvement in symptoms within days. Sexual dysfunction, such as erectile dysfunction and retrograde ejaculation, have been observed. There is always the possibility of infection, such as a UTI, and in very rare occurrences, some patients might require a blood transfusion or experience TER syndrome, which is when the body absorbs a large amount of irrigating fluid during the procedure and the sodium levels become diluted within the body. This is a serious complication, but is not common and typically only occurs during longer procedures with lengthened resection times. A more recent advancement in BPH surgical techniques has allowed for the modification of the standard TURP procedure to create a safer and just as efficacious version called the bipolar TURP. The procedure is virtually the same as TURP, except that the resectoscope retains the electrical flow within the end loop. This lets the physician use a safer irrigating fluid, sodium chloride, and significantly reduces the development of TER syndrome, as noted previously. B-TURP, therefore, may be indicated for procedures on larger prostates where the resection times might be prolonged. Research has also shown additional benefits to the use of B-TURP, such as decreased risk of retaining clots, bleeding, length of stay in the hospital, and less time with the catheter. The use of B-TURP depends on provider experience and availability in the hospital, and should be discussed with your provider to see if it is a viable option.
Long before the development of the standard TURP procedure, simple prostatectomies were performed and are occasionally used today. This involves an incision through the abdomen and bladder, then removal of the enlarged prostate. This procedure is very successful in reducing urination difficulty with low rates of failure. Complications may arise during the procedure as a result of stretching the neck of the bladder that drains into the urethra. This can cause contraction when the tissues heal, resulting in no improvement in urination symptoms. It also can result in retrograde ejaculation, where semen is forced upward into the bladder instead of out the urethra. This can impact the sexual health of men and decrease fertility. This surgery requires using a catheter and remaining in the hospital for several days.
In the transurethral incision in the prostate, it is similar in that a scope is inserted up the urethra to the prostate. The same tools as a simple prostatectomy are used to perform an incision through one side of the prostate. This works better if it is a smaller prostate and is not a great option for larger ones. Due to this simple incision rather than removal of tissue like in TURP, there may be lower rates of erectile dysfunction and retrograde ejaculation. Requirement for blood transfusion from blood loss is also lower.
In transurethral vaporization of the prostate, or TUVP, an instrument is inserted into the urethra to the level of the enlarged prostate gland. This instrument contains electrodes that heat up and vaporize the tissue of the prostate while simultaneously cauterizing the blood vessels, leading to reduced bleeding. A catheter may need to be temporarily placed in the urethra to help void urine until healed, usually 1 to 2 days. Photoselective vaporization of the prostate, or PVP, is a similar procedure to TUVP, but the instrument emits a laser that heats up and kills the tissue. This is similar in efficacy to TUVP and has a similar risk profile. Both procedures are indicated for patients at increased risk of bleeding, although many experts believe that PVP is best suited for small to medium-sized prostates. Incontinence is a rare but serious side effect, and other adverse effects include temporary postoperative irritation, erectile dysfunction, and retrograde ejaculation.
The prostatic urethral lift, or pull, is a newer procedure that was developed about 16 years ago and is relatively less invasive compared to procedures like TURP. It is specifically indicated for patients with a prostate size under 80 grams and with no obstructive middle lobe. This procedure uses a device called a cystoscope, which is fed up the urethra toward the prostate, at which point suture implants are directed through the prostatic tissue towards the outer capsule. Metal tabs are placed on either end, and through a spring-loaded mechanism, the tissue is compressed, instantly opening up through the urethra passageway. Generally, 2 to 4 implants are placed. This is a well-tolerated procedure, but does come with its own set of post-op side effects, such as painful urination, blood in the urine, urinary retention, and urinary tract infections. PUL is associated with less adverse events compared with more invasive procedures such as TURP, but have been shown to be less effective in eliminating some of the lower urinary tract symptoms. BPH surgery is usually not without its risk of sexual dysfunction as an adverse event, but for patients who are sexually active and value retention of sexual function, PUL might be a viable option. Studies have shown that PUL does not worsen erectile or ejaculatory function, and in some circumstances has even improved function in men with baseline of severe ED. Patients should talk with their providers to evaluate the severity of their lower urinary tract symptoms along with the desire to maintain sexual function when assessing if PUL is the right option for them.
In transurethral microwave therapy, or TUMT, an instrument, also known as an antenna, is inserted into the urethra to the level of the enlarged prostate. The antenna emits microwave energy to heat up and kill the surrounding prostate tissue. As the tissue heals, it also shrinks, thus increasing the size of the urethral channel through the prostate. In order to prevent damage to adjacent structures, a temperature sensor may be inserted into the rectum that records the temperature of the surrounding tissue and shuts off the antenna if the temperature of the tissue gets too high. This procedure may be done in an outpatient setting and has minimal anesthesia requirements, although evidence of efficacy and risks have shown to be inconsistent when compared to other procedures. Indications for this procedure are gland sizes between 25 to 100 grams and prostatic urethral length of greater than 3 centimeters. This treatment also has a relatively high retreatment rate after 5 years. Up to 17% of patients report change in sexual dysfunction, and up to 28% of patients report retrograde ejaculation. Catheterization time may range anywhere from 2 days to greater than 2 weeks. As with other treatments, there is a risk of a urinary tract infection and urinary retention.
Water vapor thermal therapy is a relatively new treatment that involves specific injections of hot steam into the prostate. This is also done with a scope inserted into the urethra. The steam damages and kills cells, causing them to shrink. Since it's a newer treatment, there is less supportive evidence, though it appears that risks are generally low. This may be a good option for men who want to preserve erectile and ejaculatory function. This procedure is not as effective for large prostates, but may be discussed as a viable option for smaller to moderate-sized prostates.
In laser enucleation, a laser instrument is inserted into the urethra to the level of the enlarged prostate. A holmium laser or thallium laser may be used. The difference between these two lasers is the depth at which the lasers cut away tissue. The laser is used to cut away the enlarged tissue of the prostate in sections. Another device, called a morcellator, is then inserted to break up the tissue into smaller segments and pushed into the bladder where the smaller segments can later be voided. This procedure may be useful when samples of the prostate need to be preserved for biopsy. This procedure may be beneficial for large prostates greater than 100 grams and also for patients at increased risk of bleeding. Studies show similar efficacy to the TURP procedure. Laser enucleation has shown to have a decreased catheterization time compared to other procedures, and erectile dysfunction is mostly preserved. Associated risks include urinary incontinence, urinary tract infection, and about 75% of patients experience retrograde ejaculation.
Aquablation uses high-pressure water to clear tissue from the prostate. This is a very new procedure that is used for moderate-sized prostates. For this treatment, patients do need to be under general anesthesia. There are lower prostate volume reductions with this technique, but risk of retrograde ejaculation is also lower.